Welcome to part 2 of this presentation on paediatrics. It's a continuation of part 1, so if you haven't reviewed part 1 already, we recommend that you do. Now in part 2, we're going to focus for 2/3 of the presentation on the elbow, because it's such an important area that we need to study. And then we'll go down to the lower limb and we'll look at knee and hip. Now, before we start looking at the pediatric elbow, let's just have a quick refresher of the adult elbow. So take a look at this anatomy just to refresh your memory, and you may wish to pause the slide for a few seconds and then move on. Here we have the lateral projection, again showing the normal anatomy. So you may again wish to pause the slide just for a few seconds, just to refresh yourself with the normal anatomy before we go forward.
The elbow contains anterior and posterior fat pads. The anterior fat pad is visible on a normal lateral elbow. Remember, fat on a radiograph is visualised as black, and so therefore the anterior fat pad appears as a small black triangle lying anterior to the distal humerus. The posterior fat pad is recessed in the olecranon fossa, and because of that, on a normal lateral elbow, it's not visible. Should the patient sustain an intracapsular fracture, and by that I mean a fracture that occurs within the joint capsule, as blood from the fracture site is extruded out into the joint, this increase in fluid within the joint capsule displaces the fat pads, so that posterior fat pad becomes visible and the anterior fat pad becomes elevated, bulging out like the sail of a ship. If we look at the lateral view on the right, we can see that the posterior fat pad has appeared as a small black triangle, and the normal anterior fat pad is now bulging out like the sail of a boat. If we look carefully, we can see how the radial neck is slightly angulated, indicating there's a minimally displaced fracture to the radial neck. A couple things to be aware of. If there's only been a small amount of blood extruded into the joint capsule, sometimes the posterior, if there's not enough fluid to displace the posterior fat pad. However, you should still see an elevated anterior fat pad. There are also some pathologies that cause joint effusions, such as severe degenerative changes or rheumatoid arthritis. Therefore, these patients may not have a fracture, but they may have an elbow joint effusion. But hopefully there should be enough significant abnormalities to their elbow joint for you to recognise that it's these processes that have caused the joint effusion and not necessarily a fracture. The paediatric elbow has 6 ossification centers. It is important to understand what age these appear, because otherwise fractures can be missed. We use the mnemonic tritol to learn what age these centres ossify. C is for capitulum, R for radial head, I for internal or medial epicondyle, T for trochlear, O for olecranon, and L for lateral epicondyle. The ages that these appear are on every odd year, so the capitulum ossifies at 1, the radial head ossifies at 3, and the internal or medial epicondyle ossifies at 5, and so on and so forth. What I really want you to understand is the trochlear never ossifies before the internal or medial epicondyle. This is very important. The trochlear olecranon, and lateral epicondyle sometimes ossify from multicentric ossification centers. So a fragmented trochlee, olecranon, or lateral epicondyle should not be misconstrued as a fracture. The next slide is going to look at ossification centers in an elbow of a child, and I will let you look at it by yourself, and I'll catch up with you after that.
So as Hannah says, this is just a slide to show you the location of these particular anatomical features, and remember Crital, and just make sure you know where they are again before we progress.
The anterior humeral line is a line that is drawn to identify normal elbow joint alignment. You should always use it when assessing a paediatric elbow. The anterior humeral line runs along the anterior surface of the distal humerus. The anterior humeral line should bisect the capitulum in the middle third. What happens when a patient falls on an outstretched hand is the axial force drives the radius up against the capitulum. The humerus then fractures at its weakest portion, which is the supracondylar region, and therefore this fracture causes the capitulum to be displaced posteriorly. Therefore, the anterior humeral line will no longer bisect the capitulum through the middle third. Instead, it will either pass through the anterior third of the capitulum or even more anterior than that, depending on how badly displaced the fracture site is. However, the anterior humeral line isn't relevant when it comes to patients under the age of 4. This is because there hasn't been enough ossification, and the anterior humeral line will no longer pass through the middle third, and it will more likely pass through the anterior third. But look for other signs of trauma to help you with your diagnosis in those cases. So, to recap, the anterior humeral line on a normal paediatric elbow will pass through the middle third of the capitulum. For supracondylar fractures, the anterior humeral line will either pass through the anterior third of the capitulum or even more anterior than that if the fracture is grossly displaced. The Radiocapitella Line is very helpful in identifying the normal radial head and capitulum relationship. It is a line that bisects the proximal radius and should pass through the capitellum on every view, irrespective of the position obtained. The radial diaphysis is bowed distal to the radial tuberosity, so it's important when you draw the Radiocapitella line that it should not extend beyond the neck. If the line fails to pass through the capitellum, dislocation of the radial head or displacement of the capitellum is indicated. It's especially helpful for Monteggia fractures. Remember, a Monteggia fracture is a dislocation of the radial head of radius and a fracture of the proximal ulna. A pulled or nursemaid's elbow occurs in toddlers between 2 and 5 years due to a sudden jerk on the hand by an impatient adult. The radiographic findings are normal, and condition is cured by the supination of the forearm when you place the patient into the AP view. What happens is the annular ligament, which binds the radial head to the ulna, is poorly attached to the radial neck in children under 5. So when you yank the forearm into pronation, the radial head may slip distally beneath the annular ligament as it's torn from its attachment to the radial neck. The ligament slips over the radial head and it becomes entrapped within the joint. But because the annular ligament is so slim, there's no detectable diastasis to the joint when it's entrapped. And it's the most common injury in childhood. After the age of 5, the annular ligament becomes firmly attached to the neck of radius. Medial epicondyle avulsion occurred due to a valgus injury from fall onto outstretched hand. Injuries range from simple avulsions with varying degrees of distraction all the way to entrapment within the medial joint space. The avulsed medial epicondyle is nearly always displaced inferiorly. Characteristically, there is gross soft tissue swelling around the medial epicondyle, and occasionally there may be a small flake from the metaphysis. Remember, the medial epicondyle is normally extracapsular, and because of that you don't get an elbow joint infusion. When the medial epicondyle is avulsed and entrapped into the medial joint, let's have a look at this radiograph. Let's quickly do Critol. C, capitulum. R, radial head. I, oh, look at that, there's distraction. T, no T. O, no O. L, no L. C, R, I. This patient must be approximately 5 years of age. We can see that there's a squared off appearance to the medial epicondyle centre, and it's been distracted medially and inferiorly. Look at the gross soft tissue swelling. You can see a tiny avulsion fracture from the flake of the metaphysis. So what is it? It's an avulsion and fracture. Where? Right medial epicondyle. How? Medial displacement. Let's have a look at these radiographs. Let's go through Critol. C, capitulum. R, radial head. I, oh, what's happened? We've lost the normal smooth rounded outline of the medial epicondyle. You've got this slightly squared off appearance. T, trochlee. O, olecranon. L, lateral epicondyle. We can see how the medial epicondyle has been avulsed and it lies entrapped within the joint. You can see these teeny tiny fracture fragments that are associated with it. On our lateral view, we can see this large entrapped medial epicondyle in this location. Look at the gross soft tissue swelling that's associated with this injury. Just out of interest, have a look at your lateral epicondyle. This is a normal appearance. The lateral epicondyle is normally projected off the host bone, so that there is a gap between the host bone and the lateral epicondyle, whereas the normal appearance of the medial epicondyle is that it overlaps the host bone. So what is it? It's an avulsion and fracture. Where? Left medial epicondyle. How? Entrapped within the ulno-humeral joint. Fractures of the lateral condyle are the second most common injury in childhood, and they tend to occur in individuals between the age of 4 to 10. They can either be incomplete, like these two images on the left, or complete, like these 3 images on the right. If they're a complete injury, they're a Salter-Harris 4 injury. It's important that when you look at a paediatric elbow, where you can't see bone, you think that there's absence of nothing there, but actually it's full of unossified cartilage. And so therefore, if you get a fracture through the lateral metaphysis, it may actually extend down through the unossified cartilage, and if it does, you'll see an elbow joint effusion. With gross displacement, the fracture is very easily to be identified, as it is rotated laterally and distally, and what happens is that your Radiocapitella line is disrupted. However, Very small fractures that are incomplete can be quite difficult to identify, and they can be mistaken for growth plates. Let's have a look at some radiographic examples. Okay, let's do critol. C, capitulum. Oh, what's this here? R, radial head. I, internal epicondyle. T, no, nothing there. Therefore, this must be a fracture fragment of the lateral condyle. Look at the gross soft tissue swelling. We can't actually see if the fracture actually enters into the elbow joint. However, if this patient has sustained an elbow joint effusion, we can be sure that it has involved the articular surface. Look at the medial epicondyle. Remember when I said it was very round and smooth? Plus it's also superimposing over the host bone. Okay, so what do we have? We have a fracture. Where? Left lateral condyle. How? Slight lateral displacement. Supracondylar fractures are the most common fracture of the elbow joint in paediatrics, accounting for 60% of elbow joint injuries. On a normal lateral elbow joint, you should be able to see an hourglass configuration. When patients sustain a supracondylar fracture, there is disruption to this hourglass appearance. Remember the anterior humeral line? That's the line that's drawn down the anterior surface of the distal humerus. It should bisect the capitulum through the middle third. Should patients sustain a supracondylar fracture, the anterior humeral line will bisect either the anterior third or even more anterior to the capitulum. Let's have a look at some abnormal images. Let's have a look at this lateral view first. What soft tissue signs do we use to help us with assessing elbow joint trauma? That's right, it's fat pads. We shouldn't be able to see a posterior fat pad because it should be recessed within the olecranon fossa. Here we can see elevation to the posterior fat pad. This must signify there's an elbow joint effusion. And in the context of trauma, this is caused by blood hemorrhaging out into the joint capsule, causing displacement to the fat pads. What line do we use to help us with assessing the elbow joint? That's right, it's the anterior humeral line. Let's come down the anterior humerus. It should bisect through the middle third of the capitulum, but it practically bisects through the anterior cortex of the capitulum. Therefore, the capitulum has been displaced posteriorly. Fractures occur through the weakest point. That's the supracondylar region within the humerus. Let's look at our radiocapitella line. No, that's fine, that's in alignment. Okay, let's look at the AP view. A supracondylar fracture will always pass through the olecranon and coronoid fossae. We can see the slightly more loosened appearance indicating the fossae here. And we can see the transverse fracture passing through. So, what do we have? Fracture. Where? Left supracondylar region. How? Dorsal displacement. Monteggia fracture dislocations are fractures of the proximal ulna with dislocations of the radial head. Clinically, it's very easy to identify the fracture to the proximal ulna. However, it's not possible to clinically diagnose the dislocation to the radial head. It's the Radiocapitella line that is most helpful for identifying this dislocation. So remember, with the Radiocapitella line, you draw a line from the radial neck and it should bisect through the capitellum. Here we can see the radial head, but the capitellum is located here. Therefore, the radial head has dislocated anteriorly. There's a grossly angulated fracture of the proximal ulna. So what is it? It's a fracture dislocation, Monteggia, where right proximal ulna and radiohumeral joint. How? Anterior dislocation and angulated fracture. Toddler fractures occur in young ambulatory children, usually between the ages of 9 months and 3 years. They're usually a spiral or oblique fracture, and they either affect the femur or the tibia. If they're in the tibia, then the fibula is classically preserved. They usually occur because of a twisting injury. If we look carefully, we can see this very faint lucent line of the undisplaced oblique fracture, indicating a toddler injury. Classically, if a child is unable to weight bear in a toddler, then they should be managed as though they have an occult toddler fracture. Look carefully to make sure that you don't miss them. You can often only see them in one view. So what is it? It's a fracture. Where? Proximal diaphysis of right tibia. How? Undisplaced. Osgood-Schlatter's disease. Well, it's not actually a disease. It's a form of traction apophositis. The tibial tuberosity, the ossification centre for it, can often be multifragmented, and this is normal. However, with Osgood-Schlatter's, you get a multifragmented tibial apophysis, but you get associated soft tissue swelling. This is the most important bit. Remember, a multifragmented tibial tubercle is normal, but if it's with a soft tissue swelling, then it's abnormal. Osgood-Schlatter's disease is a clinical diagnosis. However, if patients present with sudden pain, you do need to x-ray them, because quite often they are at risk of avulsions of their fragmented tibial tubercle. So what is it? It's an apophositis. Where? Right tibial tuberosity. How? Fragmented with soft tissue swelling. That's the important bit, the soft tissue swelling. Children with hip pathology may present with hip pain or a limp. The differential diagnosis can be narrowed down according to the child's age. Children less than 4 years are more likely to suffer from transient synovitis, developmental dysplasia of the hip, or toddler's fracture. Between 4 to 10 years, they may suffer from transient synovitis or Perthes. Between the ages of 10 to 16, they may suffer from a slipped upper femoral epiphysis or a sports injury. Transient synovitis, also known as coccytus fugax, is an aseptic inflammation of the hip, which is believed to be due to post-viral etiology. It's self-limiting and it's treated with rest and analgesics. Ultrasound is the preferred form of imaging, as this can identify a joint effusion, because radiographs are normally normal, although you may see a little medial joint space widening. And 90% of hip joint fusions tend to be due to transient synovitis. There are a number of different terms used to describe developmental dysplasia of the hip, DDH, and these include hip dysplasia, developmental dislocation of the hip dislocation, acetabular dysplasia, or congenital dislocation of the hip. However, the preferred term these days is developmental dysplasia of the hip. The important thing to understand is that DDH refers to the abnormal relationship of the femoral head to the acetabulum. It's seen in 1.5 per 1,000 births, and it's much more common in females. Risk factors include breech baby, multiple births, and born before the 37th week. The Ortolani jerk test, or the clunk of entry, is the sign of the femoral head being reduced back into the acetabulum. The Barlow test, or the clunk of exit, is the sign of the femoral head being dislocated out of the acetabulum. In cultures where children are carried on the mother's back with the hip flexed and abducted, it's very rare to come across developmental dysplasia of the hip. Let's have a look at a radiograph. The femoral head ossifies between the ages of 3 to 6 months. Delay in ossification is an indicator for developmental dysplasia of the hip. Remember, DDH refers to the abnormal relationship of the femoral head to the acetabulum. If we look at this image, we can see on the left-hand side how shallow the acetabulum is in comparison to the right, where the acetabulum overlies the femoral head. Compare the size of the femoral head on the left with the femoral head on the right. It's smaller in size. We can see that the femoral head has completely dislocated out of the acetabulum. The femoral head has migrated superiorly and laterally. So what do we have? We have dislocated developmental dysplasia of the hip. Where? Left hip. How? Supralateral. Legg-Calvé-Perthes disease, or sometimes just Perthes for short. It's avascular necrosis of the femoral epiphysis. It's 5 times more likely to affect boys than girls. Generally, they're aged between 4 to 8 years of age. Classically, they present with pain and limping, or the pain may often be located in the ipsilateral knee rather than the hip itself. It may be bilateral, but if it is, it tends to be successive rather than simultaneous. Okay, so what does it look like radiographically? You get flattening and fragmentation to the femoral epiphysis, otherwise known as coxoplanar. Compare the left side, how flattened it is in comparison to the right. You get an increase in density, which is secondary to the necrosis. You can get cystic changes throughout the metaphysis. And later on, you may get broadening of the femoral neck, which is also called coxa magna. And this is to increase in the weight-bearing support. Let's have a look at the frog leg view. In the early stages of Perthes disease, you may get what's known as the vacuum phenomena in the femoral head. Remember, air on radiographs is black, so the vacuum containing nitrogen is shown as a lucent line within the femoral articular surface, sometimes referred to as the crescent sign. So what is it? It's avascular necrosis, Perthes. Where? Left femoral epiphysis. How? Subchondral lucency, crescent sign. Slipped upper femoral epiphysis is a Salter-1 fracture. So remember, a Salter-1 fracture is a fracture through the physis. Because we can't see the physeal fracture, what we can see radiographically is the femoral epiphysis slipping off. It's more common in males by 3 to 1, and it presents with hip or knee pain. You may get limb shortening and reduced range of movement. You get diastasis of the physis and loss of epiphyseal height. And I'm going to discuss Trethowan sign with you. The line of Klein is drawn along the lateral border of the femoral neck, and it should intersect with the femoral epiphysis. It's important not to extend from the apophysis of the greater trochanter, because this tends to be a bit curved and that may create a misleading line. So when you draw your line of Klein, draw it along the lateral border of the femoral neck, and it should intersect with the femoral epiphysis. When you get a slip through the upper femoral epiphysis, the head slips posteriorly and the metaphysis migrates laterally. Because the femoral head slips posteriorly initially, you get a reduction in the height of the epiphysis in comparison to the unaffected side. Because the metaphysis migrates laterally, when you do the line of Klein sign, the line of Klein does not intersect with the proximal femoral epiphysis, and this is referred to as Trethowan sign. Let's have a look at that in more detail. Here we have the line of Klein drawn in on both sides. It's the same image as you were looking at just a moment ago. See how the line of Klein on the right intersects with the epiphysis. That's normal. Now look at the left. The line of Klein does not intersect at all with the femoral epiphysis. So this is Trethowan's sign. So remember, the femoral head slips posteriorly and the metaphysis slips laterally. Frog leg views are very good at identifying slipped upper femoral epiphysis. Let's look at more significantly displaced epiphysis. Here we have another example. Remember, a slipped upper femoral epiphysis is a Salter-Harris 1 fracture through the physis. So that leads to posterior displacement of the femoral head and lateral slip of the metaphysis. Let's draw in Klein's line. There, Klein's line doesn't intersect with the femoral epiphysis, therefore we have a Trethowan sign, indicating we have a slipped upper femoral epiphysis. What is it? It's a fracture, Salter-Harris 1. Where? Left proximal femoral epiphysis. How? Lateral slip. Treatment of a slipped upper femoral epiphysis is surgical pinning. Quite often the contralateral hip is also prophylactically pinned, because what happens is bilateral SUFI is relatively common, and particularly when stabilisation of the unstable side can in fact precipitate a slip on the contralateral side. Okay, so just to remind you, DDH is the abnormal relationship of the femoral head to the acetabulum. Perthese is avascular necrosis of the femoral epiphysis, and the slipped upper femoral epiphysis is a fracture through the physis consistent with a Salter-Harris 1 injury.